In this snapshot, we will be differentiating between psychiatric disorders characterized by psychotic features, including psychotic disorder due to another medical condition, substance and medication-induced psychotic disorder, mood disorder with psychotic features, schizophrenia, schizophreniform disorder, brief psychotic disorder, schizoaffective disorder, and delusional disorder. Before we dive into the disorders, let's talk about some definitions and terms. Psychosis refers to symptoms of mental illness that indicate impaired contact with reality. We divide psychotic symptoms into two categories. Positive symptoms refer to symptoms that are not usually present in healthy, functioning individuals. Another way to think about this is that positive symptoms of psychosis add to an affective person's experience, although this is not generally a desirable effect. Negative symptoms, on the other hand, represent a lack of functioning that is seen in typical healthy functioning individuals. Another way to think about negative symptoms is that they take away from a person's experience. First, let's talk about types of positive symptoms. Delusions are fixed beliefs that a person believes to be true despite evidence to the contrary. Delusions are described as bizarre if they are clearly implausible, if they are not understood by peers of the same culture, and if they are not reality-based life experiences. Examples of bizarre delusions include thought broadcasting, in which the person believes everyone can hear their thoughts, thought insertion, in which a person believes their thoughts have been inserted by an outside force, Cotard syndrome, in which a person believes they are dead or that their organs are missing, or Capgras delusion, in which a person believes that their friend, loved one, or pet has been replaced by an imposter. These are just a few examples. There are many others. Delusions are non-bizarre if they could be explained by one's culture or an ordinary life experience. That is to say that the content in this type of delusion is theoretically possible, even if it's unlikely. Examples include persecutory delusions, in which the person is being harmed, plotted against, or conspired against; erotomanic delusions, in which the person believes that they are in a love affair with someone of important status; delusions of reference, in which the person derives personalized special meanings from external sources such as songs or news reports; grandiose delusions; and somatic delusions. Hallucinations are what many lay people associate with psychotic disorders. These are perceptual experiences that are not related to an external stimulus. They can occur with any sensory modality, although auditory hallucinations are the most common type of hallucinations in schizophrenia. Hallucinations, however, can be seen with many different medical and psychiatric illnesses and should not be immediately assumed to be due to a psychotic disorder. Visual hallucinations are common in delirium, and olfactory hallucinations can be experienced before seizures. Tactile hallucinations are common with substances of abuse, particularly cocaine and methamphetamine. Disorganized thoughts refers to abnormalities in thought process, such as loose associations, tangential thoughts, word salad, echolalia, clang associations, and incoherence. Again, this finding itself can be seen in other medical and psychiatric illnesses. Abnormal or bizarre motor behaviors can also be seen in psychotic disorders. These behaviors can vary greatly, from inappropriate silliness to agitation to catatonia. Catatonia is a syndrome of decreased responsiveness to the external environment, with stupor, purposeless movements, rigid or unusual postures, mutism, echolalia, and other findings. Negative symptoms, as we said, are symptoms that represent a lack of symptoms that are usually present in most people. These include diminished emotional expression, including monotone speech, decreased use of hand gestures in communication, poor eye contact, and flattened affect; avolition, or a decrease in motivation; elosia, or decreased speech output; anhedonia, a lack of interest in pleasurable activities; and asociality, or decreased interest in social interactions. Together, negative symptoms are remembered as the 5 A's. Psychotic disorders have a lifetime prevalence of roughly 1 to 3%. Onset is more common in adolescence and early adulthood. In order to diagnose a primary psychotic disorder, you must first be confident that the symptoms are not due to normal states, such as perceptions associated with sleep states or culturally accepted beliefs, such as hallucinations associated with grief. Medical issues that cause psychotic symptoms must also be considered and appropriately excluded. Medical issues that affect the CNS and cause psychotic symptoms are numerous and include neurovascular diseases, infectious etiologies, primary or metastatic brain tumors, degenerative processes, inheritable and toxic related issues such as acute porphyria and Wilson's disease, autoimmune etiologies such as lupus and limbic encephalitis, endocrine processes, certain types of seizures, and many, many more. If psychotic symptoms solely occur in the context of a medical issue, the diagnosis would be psychotic disorder due to another medical condition. Prescribed and illicit substances can also produce psychotic symptoms. Examples include those agents with dopaminergic activity, psychomotor stimulants, hallucinogens, steroids, and anticholinergics. Additionally, withdrawal from GABAergic agents such as alcohol, benzodiazepines, and barbiturates are associated with hallucinations. If psychotic symptoms occur exclusively in the context of the effect or withdrawal of a substance or medication, we would call it a substance or medication-induced psychotic disorder. Other psychiatric disorders can be associated with or mimic psychotic symptoms, including depression and bipolar disorders. In those disorders, the psychotic symptoms only occur within the context of a mood episode and resolve during periods of euthymia. For example, if a person with depression hears voices telling them that they are worthless or commanding them to harm themselves, but does not otherwise hear voices out of the context of a major depressive episode, that would be considered major depressive disorder with psychotic features. We would expect the hallucinations to improve when the mood symptoms improve. Hallucinations can also be a feature of trauma, autism, borderline personality disorder, and other psychiatric conditions. With exclusion of other causes of psychotic symptoms, a primary psychotic disorder should be considered. You will notice that as we describe each disorder, the time course of symptoms is a major distinguishing feature. Therefore, it's important to pay attention to how long the symptoms have been present in a given individual. Schizophrenia is the prototypic psychotic disorder, so we will start with it. Schizophrenia requires the presence of at least 2 core symptoms that are active most days over a month or less if treated. One of the 2 symptoms must be either hallucinations, delusions, or disorganized thoughts. These are all positive symptoms. The other symptoms that could be present but are not necessary for a diagnosis are grossly disorganized or catatonic behavior or negative symptoms. Negative symptoms are symptoms that represent a deficit in typical functioning, including a flat affect, lack of verbal expression or alogia, poor motivation or engagement in purposeful activities known as avolition, lack of interest or pleasure known as anhedonia, and decreased social interactions or asociality. Remember those 5 A's. As mentioned, 2 of the above symptoms must be in an active state or overtly apparent for a month or less if treated. However, there must be some evidence of disturbance for at least 6 months total for a diagnosis of schizophrenia. That means that either the symptoms are present in a lesser attenuated form or there are predominant negative symptoms only that persist beyond the month of active hallucinations, delusions, or disorganized thoughts. Schizophreniform disorder is characterized by exactly the same criteria as schizophrenia, but a shorter time frame, 1 to 6 months of symptoms. In brief psychotic disorder, at least 1 positive symptom of psychosis is active for more than a day, but less than a month. And negative symptoms do not count for this diagnosis. What about those patients who present with a major mood episode with psychotic features, but the mood improves and the psychotic features persist? In those cases, schizoaffective disorder must be considered. In schizoaffective disorder, 2 of those core symptoms of schizophrenia must be met at the same time as the major mood episode. Plus, there must be evidence of at least 2 weeks of hallucinations, delusions, or disorganized thoughts that occur during a period of normal euthymic mood. Some people think of this as bipolar or depression plus schizophrenia, although that's a little simplistic. The major difference between schizoaffective disorder and a mood disorder with psychotic features is that in schizoaffective disorder, there are at least 2 weeks of psychotic symptoms that are present by themselves without a mood episode. In mood disorder with psychosis, the psychotic symptoms are only present with mood and never happen by themselves. Since schizoaffective disorder can happen with either a major depressive episode or a manic episode, there are 2 subtypes. Schizoaffective disorder depressive type, if a major depressive episode is present, and schizoaffective disorder bipolar subtype, if a manic episode is present. Confused? Let's try it a different way, since mood disorders, psychotic disorders, and schizoaffective disorders can get mixed up based on the time frame when symptoms present. Let's say you see a patient, Juan. Juan is having symptoms of a major depressive episode, and if seen during that snapshot of time, MDD would be the diagnosis. Juan comes back in 6 months and has had hallucinations for 2 weeks, but his mood has been fine. Since the psychotic symptoms have not overlapped the major depressive episode, the diagnosis at that snapshot in time would be brief psychotic disorder. Next scenario. You again diagnose Juan with major depressive disorder. However, hallucinations develop during that episode and then resolve around the same time as the depressive episode. That scenario would be re-diagnosed as major depressive episode with psychotic features. One more scenario for Juan. You see him during a major depressive episode. He develops hallucinations during that episode. But once his depressive symptoms improve, the hallucinations persist for another several weeks. The diagnosis in this scenario would be changed to schizoaffective disorder. The opposite could also be true in that the psychosis could precede the major mood episode. Let's talk about delusional disorder next. Delusional disorder is specific in that it only requires presence of delusions, hence the name. The delusion must be present for at least a month, and the other symptoms used to diagnose schizophrenia are not prominent, if any are present at all. Hallucinations might be present, but if they are, they're consistent with the delusion that is the primary issue. The delusion itself affects the person's life, but otherwise they do not have odd behaviors and tend to function well. If you suspect a delusional disorder, you should look into why the person is presenting for care, as this may help you to understand how to address the person's concerns. Often, friends and family refer people with delusional disorders for care, and the affected individual may or may not have insight into their delusional thoughts. Additionally, mood episodes cannot be present for a significant length of time for a diagnosis of a delusional disorder. If that happens, a better diagnosis might be schizoaffective disorder. If the delusion has to do with a defect in body image, you have to rule out body dysmorphic disorder. So here are a list of those disorders we just covered back in the main schema. To summarize, schizophrenia has 6 months of at least 2 psychotic symptoms, positive or negative. One of them has to be positive, and mood episodes are not a prominent feature. If an individual looks like they meet criteria for schizophrenia, but the symptoms only last 1 to 6 months, then schizophreniform disorder is likely the most appropriate diagnosis. If at least one positive psychotic symptom is present for a day to less than a month, a brief psychotic disorder is the diagnosis. In schizoaffective disorder, mood episodes are prominent, but there is also at least a 2-week period of purely psychotic symptoms. In delusional disorder, a delusion is the primary symptom, mood episodes are not as prominent, and the delusional episodes last at least 1 month.